Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Underestimation of Risk of a BRCA1 or BRCA2 mutation in Women with High-Grade Serous Ovarian Cancer by BRCAPRO, a multi-institutional study, by Molly S. Daniels et al. My name is Dr. Nadine Tung, and I am an Associate Professor of Medicine at Harvard Medical School and Director of the Cancer Genetics and Prevention Program at Beth Israel Deaconess Medical Center in Boston, Massachusetts. My oncologic specialty is medical oncology with a special interest in cancer genetics. Women who inherit a mutation in BRCA1 or BRCA2 have up to an 85% lifetime risk of breast cancer. In addition, the risk of ovarian, fallopian tube, or primary peritoneal cancer is as high as 60% for BRCA1 mutation carriers and 27% for BRCA2 carriers. The histology of the epithelial ovarian cancers that develop in carriers is more likely to be serous adenocarcinoma and less likely to be mucinous than those in women without an inherited mutation. The incidence of germline BRCA1 or 2 mutations is 10 to 15% in ovarian cancer patients unselected for age at diagnosis or family history, and is higher in Ashkenazi Jewish patients or those with high-grade serous histology. Referrals for BRCA testing are commonly triggered either by established guidelines, such as those updated annually by the National Comprehensive Cancer Network, NCCN, or by use of a threshold, such as a greater than 10% likelihood that a mutation exists. The goal of this retrospective study was to assess the accuracy of BRCAPRO to identify germline BRCA1 and BRCA2 mutations in women with epithelial ovarian cancer, including fallopian tube and primary peritoneal cancer. BRCAPRO is a commonly used computer-based statistical model that uses Bayesian analysis to assess the probability that an individual carries a germline BRCA mutation. It incorporates personal and family history of breast and ovarian cancer, age, Ashkenazi Jewish ancestry, as well as the number of relatives unaffected by cancer. In this study, the BRCAPRO score was calculated for 589 patients with ovarian cancer referred for genetic testing to one of 3 academic cancer centers between 1996 and 2011. The BRCAPRO scores of the study population were segregated by quintiles, and the number of observed compared with expected ovarian cancers for each quintile was then calculated. 3/4 of the subjects had high-grade serous tumors, 70% had advanced stage disease, 10% were Ashkenazi Jewish, and the median age was 55. The mean BRCAPRO score was 21%, and 60% of subjects had a BRCAPRO score less than 10%, used by many as a cutoff for BRCA1 and 2 testing. The authors found that 31% of the 589 subjects had a mutation. How good was BRCAPRO? Using receiver operating characteristic, or ROC curves, the discrimination was good with an area under the curve of 0.81 for all subjects, consistent with previous studies. However, while BRCAPRO almost perfectly predicted the number of mutations in those with a score greater than 40%, for the 80% of subjects with a score less than 40%, it significantly underestimated the likelihood of a mutation. This finding had a p-value of less than 0.001. In addition, 28% of the mutations identified were in individuals with a BRCAPRO score below 10%, and even subjects with a BRCAPRO score less than 5% still had a 12% chance of carrying a mutation. The model was particularly inaccurate for those diagnosed at a younger age and those with high-grade serous tumors. There was a difference in the accuracy of the BRCAPRO model between the three academic sites, possibly due to differences in populations enrolled. It should be noted, however, that the overall trend of underestimating mutation frequency for low BRCAPRO scores was seen at all sites. Finally, the study found that BRCAPRO overestimated the likelihood of a mutation in those with non-serous cancers and underestimated the probability in those with high-grade serous tumors. This finding was statistically significant with a p-value of 0.0001. Is the study population representative of the general ovarian cancer population? The prevalence of mutations in this study is higher than in studies of unselected ovarian cancer patients. The study population may have been enriched for mutation carriers for several reasons. First, it is likely that many of the subjects were referred to a high-risk program because of a family history suggestive of hereditary breast ovarian cancer syndrome. Second, since subjects were not required to have a recent diagnosis of cancer, and ovarian cancer patients with a BRCA mutation have a better prognosis than those without a mutation, the study population may have been enriched for mutation carriers due to survival bias. Third, it is not clear whether the study excluded subjects referred because of a known BRCA mutation in the family. Even if the study population is enriched for mutation carriers, why is BRCAPRO inaccurate for scores less than 40%? A lack of family cancer history can result from inaccurate family history or small family structure. In addition, BRCAPRO only captures information about first and second degree relatives. It is possible that some patients with low BRCAPRO scores had more distant relatives with breast or ovarian cancer. Can the model be improved? As the results of the current study indicate, the predictive value of BRCAPRO in the ovarian cancer population would likely improve if age at ovarian cancer diagnosis was included, as well as tumor histology, just as it was improved for breast cancer patients by the incorporation of steroid receptor status, given the association of BRCA1 mutations and triple-negative breast cancer. A more fundamental question is whether the accuracy of BRCAPRO in ovarian cancer patients matters. NCCN guidelines recommend BRCA testing for all patients with epithelial ovarian cancer. However, since universal genetic testing is more expensive than targeted testing, the investigators proposed that if BRCAPRO could identify patients for whom testing was unnecessary, it would be more cost-effective. The results of this study do not support the use of BRCAPRO in lieu of universal testing, certainly for those with serous cancers. Identifying ovarian cancer patients with germline BRCA mutations is important for several reasons. First, as mentioned previously, studies have shown that among patients with ovarian cancer, those with a BRCA mutation, especially a BRCA2 mutation, have improved overall survival and an increased sensitivity to platinum chemotherapy. Second, certain targeted therapies, such as PARP inhibitors, are more effective in treating BRCA-related ovarian cancer. A phase 2 study using the PARP inhibitor olaparib as monotherapy demonstrated that mutation carriers with heavily pretreated recurrent ovarian cancer had a 33% response rate with few significant side effects. In addition, a randomized phase 2 trial demonstrated that maintenance olaparib therapy after chemotherapy in platinum-sensitive recurrent ovarian cancer improved progression-free survival compared with placebo. While this benefit was also seen for ovarian cancer patients without a germline BRCA mutation, responses were superior for mutation carriers. Third, identifying ovarian cancer patients with BRCA mutations allows identification of relatives with the mutation for whom risk-reducing salpingo-oophorectomy can improve survival. Finally, Walsh and colleagues at the University of Washington have reported that 25% of 367 unselected women with ovarian cancer had a germline mutation in one of 21 genes studied. 1/3 of these mutations were in genes other than BRCA1 or 2, many of which are in the Fanconi anemia BRCA pathway responsible for double-strand DNA repair. Identifying ovarian cancer patients with these mutations may also lead to opportunities for better treatment through targeted therapies and chances for cancer prevention for both patients and their relatives. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.